Anusha Lachman. I'm a child psychiatrist at Stellenbosch University, and I'll be doing a practical approach to anxiety in children and adolescents. One of the first things you have to consider when thinking about anxiety in children is to ask yourself, what is normal behavior? It's important that we realize upfront that society defines what is pathological and that social rules are learned over time and at different developmental stages. So, anxiety, aggression, and fear is often a social consequence. There are essential things for you to consider before you decide to diagnose or initiate treatment for an anxiety disorder in a child. And that is to ask yourself, is a disorder present? Now, remember, children can respond adaptively or maladaptively to their environment and stresses, and these are influenced by a few things. One of the most important things is the relationship with the caregiver. And to that, we refer to attachment patterns, to the anxiety levels, and the determination of the caregiver to be able to support children effectively when they are in difficult situations, and how safe a child feels with that adult caregiver. The second is temperament. So think of it as a style of behavior. Some children are genetically considered easy children or slow to warm up or difficult to soothe. And this combination of the temperament together with the relational quality with their caregiver will determine what is considered a goodness of fit. And that goodness of fit between the caregiver and the child will determine how the child responds in a situation that is considered fearful or threatening. It is also important to remember that a child is often forgotten to be a part of the family. Donald Winnicott famously said there's no such thing as just a baby. And it's usually a critical point that we miss, that we underestimate the social cultural influences of the home, the environment, the stresses, and often psychiatric symptoms that the child is presenting with may actually represent dysfunction in the home. So the evaluation of a child for anxiety will often require the evaluation of the caregiver. So, what is anxiety? Anxiety is essentially a mood state characterized by a strong negative emotion in which a child apprehensively anticipates a threatening environment, event, or situation. It's a complex phenomenon, but we have to think about it as being expressed within three interrelated systems. Firstly, cognitive. The situation is perceived as dangerous. Secondly, physically. So it's anticipated that there is danger by physical and chemical effects. And thirdly, there is a behavioral response. So this urge that accompanies that flight fright initial response is to avoid and escape. Now, all children experience fear and anxiety, so it often makes it difficult to differentiate what is normal from pathological. So it's useful to think of a child in terms of what is appropriate developmentally. So, for example, if you have an infant who is under the age of 3, very typically an infant would experience fear of predictable things like fear of being startled, fear of strangers in the home. Typically, they are afraid of loud noises. A toddler above the age of 3 may be fearful of imaginary creatures, a monster under the bed, fear of the dark, fear of being separated from their parent. A school-going child may have different fears, so worried about natural disasters, about being injured, being late. And older children, often adolescents, may have quite personal worries and fears, so related to peer performances, school performances, social competency, health issues. The fact is that most children experience anxiety in their lifetime. It's one of the most common of all psychiatric disorders in children. It occurs across ages, across lifespans, and across socioeconomic groups. But what we have to remember is children may not come to you presenting with anxiety. They often present with comorbid conditions such as school refusal, somatic complaints, very typically headaches, tummy aches, their legs hurt, they aren't able to go to school, they're socially withdrawn. And so we have to aggressively ask for symptoms and signs that would give us an indication that this is anxiety and not just the somatic presentation. Another important thing to remember is we have to differentiate when an anxiety symptom becomes a disorder. The DSM advises that you have to differentiate on the number, the severity, the persistence, the level of impairment of symptoms, how long it takes, the intensity doesn't really correspond with real danger, if it's chronic, if it occurs in a harmless situation. One of the useful things to remember is whether or not this interferes with the normal job description of a child. So ask yourself, what is this child in this developmental stage expected to be able to do? And does this anxiety symptom that they're presenting with interfere with the level of social, academic, or psychological competency that is expected for this age group? Many common types of anxiety disorders have symptoms that overlap, and this includes separation anxiety, panic, social anxiety, generalized anxiety disorders. And they may all be classified according to the nature of the feared stimulus and how severe the anxiety response is. However, what is common amongst this is the excessive and inappropriate anxiety that causes functional impairment. So what are the common signs to look for? Very commonly, we look for children that find it hard to concentrate, that quickly get angry or irritable. They may have other somatic complaints like they're not sleeping, they're waking up with bad dreams, they're quite warring with negative intrusive thoughts, they're not eating properly, again, we've said, they're always crying, they feel quite tense, quite fidgety, quite clingy, and then the common symptoms in smaller children would be things like tummy aches, feeling unwell. Screening for anxiety should therefore be routine because, as you've seen by the list of symptoms that can present, they don't all classically fit into an anxiety disorder and may very commonly meet criteria for other disorders such as ADHD or perhaps even a mood disorder. Always make sure that you're getting collateral from more than one source. If we remember that I've said that often it's the relationship that will negotiate how a child responds to a situation, it therefore stands to reason that we have to look for more than one source of collateral to be able to support or confirm the symptoms. Always try and use child-friendly language. Children may be very well aware of the distress, so chance asking them, but use it in a child-friendly way. Very often, teachers and parents may underestimate the impact of the impairment. So it's really helpful, if possible, to get child-friendly self-report measures, especially in school-going children, and try to use tools that are kind of available. I know that's difficult in certain population groups in certain contextual situations, but there are common scales that are available online that are easy to use, that are accessible, and that have some adequacy of validity and reliability that can support that. Perhaps the take-home message with an approach to anxiety disorders is to always look for the differentials. Common things occur commonly. So physical things like asthma, treatment for asthma disorders, seizure disorders, the use of caffeinated, carbonated drinks, commonly used prescription drugs in children like anti-asthmatics, sympathomimetics, steroids, sometimes diet pills, antihistamines, cold medications can always present with physical symptoms that mimic anxiety. And then also psychiatric differentials are important in children. So think of ADHD when you're thinking of restlessness and fidgetiness, learning disabilities that can be presenting with school anxiety and refusal, the awkwardness, the withdrawal, the social skills may actually be mimicking or be confused with ASD. And then obviously mood disorders in children can also present as anxiety. And finally, your approach to managing it has to be multimodal. So it includes psychoeducation, it has to include psychological modalities, and it most definitely, depending on the severity of the symptom clusters and the level of impairment, will need to involve pharmacotherapy according to the guidelines. And of course, families are critical to getting a good response. The greater the severity and symptoms and the older the age of the child, the poorer the predictive response that you can expect from a single modality alone.